Good afternoon, everybody, and welcome to this session on strabismus and pediatric ophthalmology. We have a panel of very experienced experts, and we'll be talking of important conditions in strabismus and pediatric ophthalmology. Now, the first talk is by Dr. Rishikesh Mai. Dr. Rishikesh. Dr. Rishikesh will be talking about management of acute acquired comitant esotropia, and he has a lot of experience in this specialty and strabismus. He has done a lot of good work in both these specialties. Dr. Rishikesh, please.
Thank you, Dr. Pandey, sir. Thank you, SPOCI and the Scientific Committee of AIOS for this wonderful session on pediatric ophthalmology and strabismus. I'm Dr. Rishikesh, and the topic of my presentation is management of acute acquired comitant esotropia. I'll start with one case of a 18-year-old female who presented to me with sudden onset inward deviation of eye. Predominantly, it was the right eye and diplopia. It was a binocular diplopia, and the patients suggested that the diplopia was almost same in all positions of gaze. There was not much of a difference. We did a diplopia charting and found that the diplopia was almost the same in all positions, and there was no positive history systemically, no history of trauma or a viral illness. Her visual acuity uncorrected was 6/6. Anterior and posterior segments were normal, and she didn't have any refractive error. So, based upon, this is the video of the same patient. You can see that it appears to be a comitant esotropia. There is no limitation of movement, especially in abduction, because sixth nerve pulse is more common when we actually consider a patient with esotropia and diplopia. We did a MRI, which also turned out to be normal, and blood tests, for especially the routine HbCb CSR, was also normal. She was hence diagnosed as a case of acute acquired comitant esotropia, and there was no much change over 3 months of time. So we advised surgery for her, a bimedial recession of 6.5 millimeters. We had a residual of around 5 prism diopters, but that's what we usually aim for in the beginning of esotropia surgery. So coming to esotropia can be congenital and acquired. Congenital most common is infantile esotropia, or rarely it can be congenital sixth nerve palsy. Any esotropia which presents after 6 months of age, we consider it as an acquired esotropia, which can be comitant or incomitant. Comitant is accommodative, that is related to the refractive errors, or it can be non-comitant, in which includes cyclic esotropia, sensory esotropia, and AACE. Incomitant can be paralytic, which is sixth nerve palsy most commonly, or restrictive, as the list suggests. So coming to acute acquired comitant esotropia, they are being classified into 3 types. Though type 3, that is Belchowski type, is related to high myopia, it is believed to be with fibrosis of the lateral rectus and contracture of the medial rectus. So many of the clinicians, they classify it as a restrictive strabismus and not as a part of AAC. Type 1 is related to history of occlusion, most commonly anisohyperopic amblyopia, but also because of chalazion or removal or foreign body removal. Type 2 is most common, that is Franchetti type. I'll be sharing the clinical features now. So type 1 is related to history of patching, and there is breaking of the fusional amplitudes after disruption of the binocularity. The problem is once the binocularity is established, the strabismus still remains in many of these cases, and we need to look for a refractive error, treat them accordingly, but many of the cases will need a surgical correction as well. Coming to type 2, which is also called Franchetti type, the patient which I just showed seems to be in that category. It usually presents in first or second decade of life with sudden onset esotropia with diplopia. The esotropia is a large angle, somewhere between 25 to 50 prism diopters. The neurological examination and neuroimaging is normal in these cases, and many of the clinicians feel that there is no need of doing a neurological examination, but we need to rule it out, especially at some abnormality at the CP angle, before we diagnose it as AACE. Sometimes mild myopia might be associated with these conditions. Just a brief flow chart about how to manage a patient with acute comitant esotropia with diplopia. Rule out that there is history of patching or any positive history. If patching is present, consider it as type 1 and correct the refractive error, and for residual esotropia, the patient will need surgical correction. Coming to there is no positive history, you do a neuroimaging to rule out any neurological condition. If neuroimaging or MRI is positive, you would take a neurologist opinion, and for the residual squint or alignment, we will need surgical correction. The treatment protocol are there are no clear-cut guidelines as far as AAC is concerned, but we follow the same as for any comitant esotropia. Clinicians have used botulinum toxin for esotropia less than 25 prism diopters by in both the medial recti, but anything beyond that will need surgical correction. The surgery of choice is bimedial recession, and usually the alignment results are good. Binocularity or binocularity depends upon the age and stage at when you are operating. So either the most commonly done surgery is a bimedial recession. If it is planned earlier with frequent follow-up of the patient, the tone of the muscle is the same as what you get for a normal patient. So there is not much of a contracture or contracture of the medial rectus. Very rarely you might have to do 3 muscle surgery, or if the patient insists on getting operated only one eye, then we might have to do a recess resect or resection of the lateral rectus as well. It can instead of this, plication can also be tried, but I haven't done that so far. So before I close, I just wanted to share one patient. She had appeared to be a case of AACE. The only positive history which she had was a smartphone use of more than 6 hours. I had not presented this case had it been pre-pandemic period, but this is something very important because there are clinicians who have reported even Indian studies suggesting AAC because of excessive gadget use. So usually she needed surgery, and the surgical results are good. So to conclude, AAC is an important cause of sudden onset comitant esotropia. Many of the cases you need surgery or botulinum toxin can be used. They have good alignment results, and always ask history of excessive gadget use when you are considering AAC. Thank you.
Thank you, Dr. Rishikesh, for a very nice presentation. I think a few things we have to keep in mind. One is that accommodative esotropias can present initially, but the age group is about 1.5 to 2 years, most of the accommodative esotropias. And the AAC age group is usually older, about 7-8 years. And what we have to remember that once in a while you may have serious neurological disease like a tumor or some kind of those conditions one has to keep in mind. So if it is worsening, if there is, and also need to look for maybe some sign like nystagmus or papilledema. So they need to be examined in a bit more detail in a comprehensive way, so that those possibilities are ruled out. Otherwise, of course, neuroimaging has to be done. If it is not getting better by, I think, at least 3 months, you must do a neuroimaging. And of course, good refraction. Anything, Shubhangi?
Just one comment I wanted to make is the type 1, type 2, type 3, normally we classify it like that, but there's a thin line between the types, and sometimes it is better to classify it as small angle less than 20-25 prism diopters and large angle more than 25 prism diopter, which helps us in management also. And yes, but sometimes that may not work. And one suggestion is it's better to keep these patients on adjustable suture, because we need an exact alignment, because they have a very good potential for binocular vision.
And these ones with CNS involvement, they don't have motor potential, they don't fuse because of obviously CNS lesion. So if there is no motor fusion, that is one of the parameters to suspect that there could be CNS involvement. Thank you, Dr. Rishikesh. Anybody would like to say anything from the audience? So with that, we move to the next talk by Dr. Sumita, and she'll be talking on optical interventions in myopia control. Dr. Sumita has done extensive work at Shankar Nethralaya, Chennai, and she needs no introduction. Dr. Sumita, please.
Really?
Then I think Dr. Subhash can present. He'll be talking about minimally invasive strabismus surgery.
It's there. It's there.
Dr. Subhash has a lot of experience in strabismus and pediatric ophthalmology. and he needs no introduction, or all of us, we know about his contribution to the society.
Actually result चांगले आहे कारण की त्यांच्यात बायनॉक्युलर पोटेन्शियल चांगलं असतं तर ते जनरली डू वेल विथ वन सर्जरी नाही होत वॉल्यूम.
So basically various type of lesions has been described in strabismus surgery. And this minimally invasive strabismus surgery was popularized by Dr. Mozon in 2007. Basically for starting this minimally invasive squint surgery, you need the good microscope. Start with the primary horizontal rectus muscle recessions and plaque lesions of 4 mm or less. Preferred age group is between 14 to 40 years because in very young patients, abundant tenon's tissue makes it very difficult, and in older patients, the conjunctiva there is chances of conjunctival tear, and the ideally it should be done in these age groups. These are the various instruments. So basically in minimally invasive squint surgery, the muscle are operated through several keyhole openings instead of one large opening, and tunnel is created between cuts for additional surgical steps, and transconjunctival suturing technique is used to keep the keyhole opening small. Basically, we have conducted a study regarding this minimally invasive squint surgery with conventional strabismus surgery, and 2 groups were there for the patients, and the outcome was assessed. So basically the outcome was assessed in terms of conjunctival redness, swelling, which was graded into 0, 1, 2, 3 as absent, mild, moderate, and severe, and eyelid swelling, and secondary outcome was final alignment. So basically in the surgical technique, 4 points are marked on the conjunctiva, 2 at upper and 2 at lower end of the rectus muscle insertion, and 2 at the posterior limit of the planned paramuscular conjunctival incisions. 2 small radial cuts are made, one along the superior and other along the inferior muscle margin. Anterior extent of the cut is at the level of the tendon insertion, and size of cut depends on the amount of muscle to be displaced. Basically, the rule of thumb is the incision size should be 1 mm less than the amount of muscle displaced to be achieved. Episcleral tissue is separated from muscle sheath and sclera, and after identifying the border of muscle, it is hooked. And to perform the recession, 2 sutures 60 were applied at the superior and inferior border of the muscle tendon as close as possible to the insertions. And after measurement of the amount of the recession, the tendon was reattached by hangback techniques, and conjunctiva was closed with 60 sutures. So this is a preoperative photograph in group A, and this is a postoperative photograph on day 1. This is postoperative photograph on day 7. And this is at 3 weeks postoperatively. And in group B, the conventional strabismus surgery with limbal approach was done. And this is the preoperative photograph. This is post-op photograph at day 1. This is at day 7. It is at 3 weeks. So post-operatively, the assessment criteria were eyelid swelling, conjunctival redness, and chemosis. Basically, there was no significant difference between both groups regarding the preoperative and postoperative amount of the deviation. However, significant statistically difference was seen in severity of redness in both groups at different point of times, and conjunctival redness was almost absent by 3 weeks in the minimally invasive squint group as compared to the conventional group. Then there was statistically significant difference in the severity and mean swelling in both the groups at different point of times. So however, after 3 weeks, both the groups have similar outcomes. So whatever differences was there, that was between in the initial 3 weeks. So advantages of minimally invasive squint surgery includes the placement of conjunctival incisions away from the cornea, then minimizing the size of the incision, improved postoperative quality, better cosmesis, minimal tissue disruption, and improved function of the affected muscle, less trauma to the operative area, and ease of performing the revision surgeries. So I would like to conclude that this minimally invasive squint surgery should be tried in whatever cases it is possible, and for initial 3 weeks it is better technique as compared to the others. Thank you, sir.
Thank you, Dr. Subhash. I think how much is time taken? I think you would be probably taking more time with minimally invasive as compared to.
Sir,
say,
in the initial
Fornix
learning
based.
cover, the time will be more, but once you perform, then there is not much difference.
And other thing is younger children, you can't do in older
Yeah.
people. Younger children do have
Sir,
lot of teenagers
the-
also. So
yeah,
I
so
think it
ideal
becomes-
group is 14 to 40 years.
But by 40 years, conjunctiva starts getting fragile. So
Yes.
it's better to probably have a fornix incision. I mean, limbal incision, older people, limbal is better than having a
Yes.
fornix one. So it's good procedure, but I think one has to select patients.
Selection criteria is very important.
And ultimately, results are similar, so it's
Yes.
not very different.
Yes.
Thank you, Dr. Subhash.
Thank you so much.
Thank you. Dr. Sumita, are you ready with your presentation? Till time? Okay, thank you. So next talk will be by Dr. Pradeep Deshpande ji, and he'll be talking about amblyopia, practical tips, innovations, and visual gains. Dr. Pradeep Deshpande will be talking about amblyopia, practical tips, innovations, and visual games. Dr. Pradeep has a lot of experience in this sphere, and he has done tremendous work, very good exemplary work in amblyopia management. And he has done some patents have also been made by him, and he is very innovative and very hardworking person. Dr. Deshpande, please. ये तो मेरा लग गया है. This is my presentation. Dr. Deshpande का अलग है, मेरा लगा.
I am very much thankful to the organizers, especially the chairman scientific committee, for sparing this hall time for our session. I am very much thankful to our secretary, Dr. Pandey, for the most active secretary of SPOCI. He is doing an excellent job for SPOCI, and I am very much thankful to our President-elect, Dr. Shubhangi, and Dr. Vaishali Une also for sparing their time for today's session. Yeah, Urmila too. Hello, good afternoon. I am going to talk on basic things of amblyopia, especially the few practical tips which I am experiencing during my practice of last only 50 years. And some innovative things which came out from my own practice and vision games. Well, all of you know that amblyopia is a common disorder. Prevalence is almost 3 to 4% all over, even in developed countries, and almost 8% in prevalence is in developing countries. Timely diagnosis and management of amblyopia is a crucial because of visual loss is correctable if appropriate measures are applied at appropriate time. Diagnosis and treatment at the earliest is very important. Diagnosis and treatment at the earliest age may prevent amblyopia from settling down. Our aim should be to utilize the most critical and the plastic period of visual development. That is my first thing that I would like to do. Most of the vision therapies, they are tackling the cases after 6-7 years, and till then, in many cases, the amblyopia gets sets in. Well, everybody knows that our precious, meritorious 2 to 5% new generation, they are thrown out of competition from class 1 jobs with a level of visually unfit due to amblyopia. And as per the recent advances, if you know the recent advances, then only you can plan your treatment schedule. You can change your treatment, type of treatment. Amblyopia is a binocular dysfunction. It is not a uniocular or binocular disorder. it is always a binocular dysfunction. In fact, the major mechanism is not the lazy state of one eye, but the active inhibition of the amblyopic eye by the dominant eye. If you close the dominant eye, you will pull the legs of the amblyopic eye where you are going to stimulate. So, it is active inhibition of the amblyopic eye by the dominant eye which disturbs the equilibrium between the excitatory and inhibitory signals. So, this needs to treat binocularly. There are more than 100 research papers are there where they are trying to treat all the cases binocularly. Well, another important thing I would like to stress, it is a plethora of multiple visual function deficits apart from visual acuity. It needs to tackle the other multiple visual function deficits in addition to improvement of visual acuity as a complementary routes for the development of stable and high quality vision. You must have observed that even after getting 20/20 vision or 6/6 vision, the vision goes back again within few days or few months. Regression is very common in more than 25 to 50% cases. Why that happens? There must be some other factors are playing. Those that we have to again think and rethink on this particular aspect. And so we have to tackle the other visual function deficits also. These are different people. These from USA in 2021, 2022. These many people, they are trying to tackle the other multiple visual function deficits, trying to treat that particular aspect like contrast sensitivity, stereo acuity, binocular vision. If you try to treat these other things also, then chances of you are likely to get a stable and high quality vision. I always stress on prevention is better than cure. A academician has rightly said, the management of amblyopia should be started when the head is born but the body is yet to be delivered. Is it possible? Yes, our mother, they used to treat our babies by keeping 2 dolls over the cradle of the child. This is not just for entertainment. This will help you to develop the binocular reflexes of that baby also. And you can assess the visual acuity of a baby, pre-verbal babies like this, which I have shown in these pictures here. And you can assess the visual acuity at home. In this case, then to overcome the phobia of hospital phobia, you can show them that baby, A for apple, E for elephant, these pictorial charts, and you can start screening the amblyopia at a very early age. This visual acuity assessment and improvement system got patented, and one of the important software of that particular patented system is that there is a modified crowning phenomena for the diagnosis, prognosis, and assessment of depth of visual acuity in amblyopia. So here we can measure the prognosis in terms of millimeters in that software, whether it has gone down or it has increased. Another important thing I would like to tell you, in all cases of congenital cataract or central cataract, central corneal opacity, uniocular ptosis, in all these cases, you can start treating the babies as a prophylactic measure by dolls or dilating the pupil, keeping a flickering light over the cradle of the child. You can put a Tixo tape on the lid by keeping the cornea moist. And after the age of 2 years, you can provide them a tab for binocular as improvement of binocular vision. The same thing I am telling you, Dr. Rishi has already told you about in congenital esotropy and all these things. I always tell others also that everybody should when they want to operate any baby below 3 years of age, please dilate the pupil before surgery. Cycloplegic, do a cycloplegic refraction on the table, then you can call a retina person also. See that if there is any retinoblastoma or anything, or any maybe other cause, or at the time if when you tackle the treat the refraction perfectly, then you can provide glasses afterwards very nicely, and then only can get a good answer. This is one of my slides, that is Theochrome plus astigmatic fan, a combined slide which is in my, I have prepared. The most important thing is in all cases of amblyopia, refraction, it should be performed under cycloplegia, and always try to tackle, see that the astigmatic fan and duochromes are well balanced. Then only there are chances of, and these are the different games. Just 1 minute.
We are running short of time.
Yeah, last a few seconds. This is one of my patented thing. This is one of paper at IJO 2018 for treating the astigmatism cases. Miridolinal amblyopia is very common if the cylinders are very high, known for their something gone. And there is a book
Next book.
on amblyopia. You can get it in market.
Sumita.
And these are all home-based
Sumita.
treatment.
Done.
And you are most welcome for the All India conference at Aurangabad on 24th and 25th of June. Please register and enjoy that conference. Thank you very much.
Thank you, Dr. Deshpande, for a very interesting talk. And amblyopia is a very difficult and very vast topic. And you have been doing commendable job. We appreciate that. And I think you will continue doing good work on amblyopia. And a lot of innovations will come in. Next
Thank
talk
you.
is by Dr. Sumita.
So I
Please,
hope
go
you're, yes, it's ready. Dr. Sumita ma'am, please.
Good afternoon. I hope everybody had a good lunch. So I'm going to talk on optical interventions. I'm going to focus a little bit more on which are actually working. Okay. So this is, we all know, this is how we define myopia, and the prevalence of myopia at this point in school, that too in urban schools, is touching somewhere around 22.9%. And of these, high myopes are likely to be 2.7%. And it is estimated by this paper, which I have quoted below, that it's going to touch around 49.8% by 2050. And high myopia is also going to increase that much in proportion. So we are looking at alarming numbers, an alarming number of children developing moderate to high myopia, requiring a huge amount of care in their 40s. So all the myopia interventions were probably designed with the idea of providing some way to retard the progression of myopia from moderate to severe and from mild to moderate. So now the various optical interventions which are available and have been tried, one is of course optimal correction of the glasses. There was at some point a small theory that under correction works, but there has been, that theory has been debunked, and I think there is no role for over or under correction in myopia, even in younger children. Now the second option which is available for us is peripheral defocus correcting lenses, or what we call as dissociated, which have an element of deep peripheral defocus built in. Bifocal spectacles as well as progressive addition spectacles have been used. And then, of course, there are contact lenses, which we will go in detail one after. So the most probably the largest data available, which has some successful outcomes, has been both using dissociated, I always get stuck in this integrated multiple, defocus integrated multiple segment, that is what is DIMS. And they provide a little bit of a peripheral defocus. So if you look at the, is there a pointer? So the principle of the glass is that centrally, if it is appropriately, if the glass is appropriate correction in place, this is where the central optical zone is focused at the retina. But the peripheral rays provide a little bit of, because of the curve of the retina like this, they are focused actually a little bit behind. And this is the driver for eye elongation, because eye tries to elongate to get all the rays in focus. So if we can produce a defocus zone which will in fact make these peripheral rays instead of hyperopic, which will happen with a single vision lens, then this elongation of the eye mid peripheral. So there is enough evidence to show that mid peripheral retina and this hyperopic defocus is what drives the elongation of the eye. So if you can produce a myopic defocus of these peripheral rays, you can prevent or slow down the progression. So this is what both DIMS and HALT technologies are intends to do. They provide a ring of peripheral defocus, which provides a little, and they are slightly in HALT technology. It is really a ring of lenslets, which are producing a ring of highly aspheric lens segments, and in DIMS it is lenslets of around +3, which consist of this peripheral zone. So if you look at the design of HALT or this, there is a central optical zone and there is a peripheral zone of defocus, 9 millimeter in case of DIMS, and I think 10 to 12 millimeters in case of HALT. So this peripheral defocus is produced by different optical elements in two technologies, but the principle remains same, that you are going to produce a little bit of a myopic defocus in the periphery instead of hyperopic defocus, which will happen if you give a single vision glass. So again, how well is it working? The data is available more for MyoSmart or DIMS lenses, which shows a myopia progression retardation by 52% and also axial length elongation retardation by 62% compared to single vision glasses. We have it available for both single vision as well as we have it for both 6-year data also corroborates compared to 1-year data. Now this is the study which I was quoting. As you can see here, there was definitely a progression retardation, and those who are interested can look at this study, which is the landmark study. HALT, as I said earlier, used the same. They were also equally effective, 67% on an average, but rider was they had to be worn at least 12 hours a day. This is a study which comes up with the use of HALT lenses, and you can see here they are. How do they compare with each other? There is only one study available which came out looking DIMS HALT slightly better than DIMS, but not great difference. I have very little experience with HALT, but DIMS, which is a longer experience, we are having a little bit better data on that. Bifocal and multifocal contact lenses have been tried, and they probably work best in situations where there is a little bit of esotropia for near or disparity in the esophagus. But generally, compared to the other optical interventions, other special spectacles which I said, they did not offer that much of retardation, maybe 20 to 25, and in spectacles even less than that. Contact lenses a little bit more effective in children who had esophoria for near, but almost not effective for other children. Now, dual defocus contact lenses are also FDA approved. That's the only FDA approved multifocal lens for myopia management. It is daily disposable, and again it has the same principle, creating a peripheral myopic defocus, and that has proved almost as effective. If you look at 55 to 60% reduction in the axial length elongation and refraction, then this compares well with other two spectacle lenses. But there is definitely not much difference as far as the myopia progression is concerned. Orthokeratology, which is reshaping or flattening of the cornea to reduce myopia, and overnight use of these lenses definitely not only eliminates the daytime spectacle wear, but also slows down the axial length elongation. And central corneal flattening, which is in the center, is also associated with a peripheral steepening, and that's what produces the defocus effect. It was an unintended effect that it also started working for myopia control. And reducing the back optic zone diameter increases the efficiency of these glasses more.
Dr.
They are
Sumita, we are
again-
running
yes,
short
sir.
of time,
Yes,
please.
Sir. Yes, sir. Last slide, sir. So they are effective in younger children, in rapid progressors, in high myopes, but microbial keratitis, especially in our country, remains a concern. Thank you so much.
Thank you so much. I think we're running short of time. Only one thing we want to say that these are working at the afferent arm, what you're talking optical
Yes,
devices,
yes,
and
yes.
the atropine is working on the efferent arm.
Yes.
So a lot of work needs to be
Lot
done.
of
It's a
work
very
needs to be done.
challenging area.
They are all very expensive options at
That's-
this
the
point.
cost is a big
and
factor.
cost is a big factor.
Just
So-
want to ask one, at what age do you prescribe these DIMS or lenses?
Youngest child I think we have done is around 6 years.
6 to 12.
6 to 12 is
that
what has
the-
been studied
till now.
till now. But I think Atom 3, which is looking at slightly younger children, probably has an arm with these.
It's a vast topic. I think with that we move to the next talk by Dr. Elizabeth. She'll be talking about
Extraocular muscle.
Dr. muscle pulleys, which is again a very interesting and challenging area. Lot of work has been done and lot needs to be done.
Please set the timer once ma'am begins.
हाँ?
7 minutes.
Timer.
7 पे कर दो अभी.
Set the timer.
हाँ. बस भी हमारा 20 मिनट बचा है. 3 टॉक है. नहीं 4. चलो मैं 5 मिनट कर दूँ. 4 टॉक है. 20 मिनट बचा. 4 टॉक बचा.
I will be talking on muscle pulleys, the current concepts. Muscle pulleys are structures of connective tissue and smooth muscles that connect the extraocular muscles to the orbital wall, located behind the equator, and they act as secondary origin of the rectus muscle. And this is the birth of a new concept was given by Joseph Demmer et al. And according to him and by histological analysis, we have found that each rectus muscle has got a global layer and orbital layer, and the orbital layer inserts to the pulley. And these pulleys shift positions during contraction and relaxation of the extraocular muscles, dynamically changing the biomechanics. And my talk is based on these different articles published by Dr. Demmer, Clark et al., Rosenbaum, etc. And disorders in the location and stability of the pulleys can create patterns of concomitant strabismus that may mimic oblique muscle dysfunction or cranial nerve palsies. There are different types of pulley pathology. There may be pulley heterotropy or displacement and pulley instability. This can be diagnosed by orbital imaging. Pulley abnormalities can be developmental, like in abnormalities of orbital anatomy, craniosynostosis syndromes, or in acquired disorders. In acquired disorders, there are 4 different categories. It could be connective tissue disorders like Marfan syndrome, Ehlers-Danlos, or globe size disorders, as in high myopia, senile degeneration like sagging eye syndrome, and in different types of traumas. This is the coronal MRI of a normal person. First picture is of a normal person. You can see a normal arrangement of the superior rectus, medial rectus, inferior rectus, and lateral rectus. And the 2 diagrammatic representations show displacement of the muscles due to pulley problems. AV pattern also can be caused by pulley displacement. In A pattern, the lateral rectus pulley is superior, and in V pattern, medial rectus pulley is superior in relation to the other muscle. In Y pattern, it could be a superior rectus pulley displaced laterally and lateral rectus pulley displaced downwards. And how will you diagnose a pulley abnormality? It's very difficult to diagnose. When you get a poor response to a standard surgical procedure, you can think that there may be some pulley abnormality. And another thing is that before surgery, observe the position of the medial canthus, lateral canthus, and the globe. If there is some asymmetry, then you can think that there could be some problem. And of course, you can do a orbital imaging, and also you can look at the upper lid. Upper lid crease may be deep in case of pulley abnormality. And in acute in axial myopia with acute esotropia, the history is always there. And coming to some surgical procedures of pulley abnormality, one thing to note is that optimum treatment for pulley abnormalities is yet to be established. There are novel techniques that reposition and stabilize the pulley within the orbit, like equatorial myopexy, pulley posterior fixation, etc. You can use permanent scleral sutures or silicone bands. This is the loop myopexy, very popular in axial, high axial myopia with sudden onset of esotropia. This is the Yamada's procedure in which there is hemi-transposition of superior rectus and lateral rectus. This surgery is very popular nowadays. And the same condition of extreme esotropia in axial myopia can be treated by the Yokoyama's procedure, that is looping of the superior rectus and lateral rectus with a silicone band. And pulley posterior fixation is another surgery which is very effective, mainly done for convergence excess ET, where there is a distance near disparity. For example, look at this child who has got a distance ET of 30 prism diopters. Near angle is much more, 45, and it is a partially accommodative deviation. In this case, if you do a standard surgery, either you will undercorrect for near or overcorrection for distance. That is a possible thing with a medial rectus recession. If you combine pulley surgery along with the medial rectus recession, the surgical result will be better. This is a video showing the medial rectus recession going to be completed. Medial rectus is in an esotropia. I have completed the medial rectus recession, and now I am searching for the pulley. It's very difficult to identify the pulley. You have to go behind, at least 12 millimeters behind the insertion, pass your muscle hook and search for the pulley. The pulley is identified by its resistance and a particular white glistening appearance, which you can see now. When that's a white glistening appearance which is different from the rest of the fascia. And once you identify and once you make sure that it may be related to the pulley, you cannot be 100% sure, but the fascia there which is adherent to the muscle and that is a particular color and resistance to pulling, then you identify it and then you pass a non-absorbable suture through the pulley, non-absorbable suture, and then pass the suture again through the muscle much anterior, so that when you put the suture about 4 millimeters behind the new insertion like this, you are pulling the pulley anterior and making the pulley very tight. So similarly, you can do the same thing in the other side of the medial rectus muscle, and it's an easy procedure. The surgical results I'll show you. Postoperative orthophoria for near and distance, the pattern is collapsed. So this is a good surgery, and this will reduce the need for Faden surgery. Faden is a little more difficult. It involves scleral sutures. The risk of scleral perforation is there in Faden. Here, in posterior fixation, there is no such thing. Another indication for pulley surgery is the sagging eye syndrome. Sagging eye syndrome usually occurs in old age. Patients presents with a divergence paralysis esotropia. For distance, there will be esotropia and diplopia, small angle esotropia.
Dr. Elizabeth, we are very short of time.
Okay. And in that case, you can do LR resection with equatorial myopexy. And to conclude, I would say that we have made only a start in this direction. And new procedures than those currently available to treat strabismus and related disorders may emerge shortly. Thank you.
Thank you, Dr. Elizabeth, for that wonderful talk and giving us an insight into the new mechanisms for oblique and vertical squints. And with this, I request Secretary Dr. Pandey sir for his talk on some difficult esotropia entity. 7 minutes, sir.
Thank you, Dr. Shubhangi. We'll be talking about some difficult esotropia entities. As So one thing we should keep in mind when we talk of strabismus that we are actually born with two parallel monoocular visual systems, and binocularity is a learned language. It's like learning language. So whatever happens, if there is a problem, if there is an obstacle, so this binocularity is not going to develop, and we will have a strabismus. Same thing happens with infantile issues, for example, that because of the problems with binocular wiring, you get into all these difficulties. And these are, we are trying to fix them at the peripheral level, whereas the problem is at the central nervous system. So we got frontal eye, we got into binocularity, and all these problems arose. And this union is a bit fragile. If it is broken, then it can end up in divorce. So we must ensure that when children are younger, they need to have proper correction of glasses and proper alignment so that they don't get into all these issues. Now, if there is a poor wiring in the occipital cortex, then you will have return to primitive monocular systems. As I said, there will be primary inferior oblique overaction and superior oblique overaction because monocular animals, they use their obliques rather than recti. If the fish has to go down, the obliques are at work. Once we got binocular, obliques were put down and recti took over. So that's one thing. Another thing to keep in mind. DVD is because of the dorsal light reflex. As the animal is turning, as it goes up, this eye will, the eye which is having less light tends to go up. So you have DVD. Same way about latent nystagmus and SPA. So all these things which we see clinically, they have a bearing on our past embryologically. So esotropias, infantile esotropias are very, we understand they are very different. The difficult entities as I would like to talk about is infantile, partially accommodative, esotropia with myopia, particularly with high myopia, esotropia with cerebral palsy, CVI and hydrocephalus, and ROP and esotropia. Now, infantile ones, we know they have large deviations, they are freely alternating, by and large they don't have amblyopia, and there's pursuit asymmetry and DVD and inferior oblique overaction, all these factors give them away. So we know that this is infantile. At times they may have an accommodative component, important to take care of that accommodative component. Otherwise, you will end up doing surgery which is not appropriate, or they may also have a DHD. If you don't take that into account, then you may do more surgery and they go for consecutive exo. These are the associations. Very often you have a cerebral palsy, you have low birth weight, you have prematurity, so all these things are associated. So whenever you have a child, you must look at these things also. And there are a lot of functional deficits in infantility, like absence of motor fusion, absent poor stereopsis, alternating monoocular suppression, subnormal VPs, asymmetric monoocular tracking, and asymmetric motion perception. So it is not just misalignment. A lot of things are happening in the brain which need to be looked into. This is showing if they are not treated early, they will have inferior oblique overaction and DVD, and all those issues will appear. Of course, it can happen in earlier age group also, even if they are treated, but the chances grow higher as if they are treated later. So treatment is mostly surgical, and early surgery is important. You must do them before 8 months or by 2 years, and if you do them after 2 years, you are likely to have poor binocularity. So it is always important to catch them young and do surgery early. Accommodative, we just refractive, no problem. Partially accommodative and non-refractive with high ACY ratio, they are difficult to handle at times. So we need to look at that. Is it partially accommodative? If they have not looked after in early age, they will go for partially accommodative. Or if there is anisometropia or there is astigmatism, so all those factors, or the amblyopia. This is showing a young child, the parents get very disturbed. Suddenly they find the eye is gone into ESO. And so it's very alarming situation. This is partially accommodative. Despite correction, they don't get corrected. So you need to correct their entire error. At times you have done under cyclogic. So the entire hypermetropia has not been uncovered. So you need to do them under atropine. And some of those who are with high ACY ratio, they may even be myopic or emetropic. So it is not essential that they are all hypermetropic. This is showing another partially accommodative deviation. Quite often they have amblyopia in one eye, and they may have anisometropia also. So we need to look at that. Non-refractive accommodative usually have high ACY ratio. They may need bifocals.
Sir, can I request you to, there are 2 minutes left.
Yeah,
But,
I'll finish in 2 minutes. So these need Farden maybe and bifocal glasses. So as I said, Farden or bilateral MR recession in these cases. And this is acute acquired competent esotropia. Dr. Rishikesh has already talked about it, and we had a lot of these in COVID, so I'm not going to talk in detail about this. This is another one because of we had this acute acquired competent esotropia in a young child, and he had CNS tuberculomas. You can see extensive tuberculomas in this child, in the brain, particularly in the cerebellum, and these ones can give rise to acute acquired competent esotropia. So if they're not responding, so you need to neuroimage. By 3 months, if they're not responding, neuroimaging is important and should be done. This is the same child after treatment, he improved, and this is another condition which we encounter once in a while, esotropia with high myopia. What is happening here? Because of the axial growth of the eye, the lateral rectus gets displaced down and the superior rectus gets displaced medially. So this pushes the globe down and in, and just conventional surgery like recession and resection is not going to work. So some kind of myopexy has to be done in these cases, and if there are large deviations, the MR gets very tight. So that also has to be recessed by and large if they are over 40 prism diopters. Like in this case, you can see both eyes are in a convergent position. Then you have esotropias with high myopia with ROP. The ROP myopia is different with prematurity, that there is the problem with the cornea and the lens. They are not emetropizing. So it's not about the axial length, it is more about the cornea and the lens, which are not losing their power because of lack of emetropization. So the problem is with the anterior segment rather with the axial growth.
Can you please conclude, sir?
I finished.
Yes.
This is esotropias with cerebral palsy. These, as I said earlier, they are very special children because they have a lot of other cerebral visual impairment and all those issues. So they need special care. This is with CFUM. And to conclude that we have to have these conditions which need a special treatment, and we need to catch them young and treat them accordingly. Amblyopia has to be treated. If they are infantile, don't treat them like other ones because they are separate class of conditions where CNS, the brain is involved, and eye, it is just being manifested. So we have to look at the brain and the effects rather treating the peripheral aspect of it. Thank you.
Thank you, sir. Thank you so much. I now request Dr. Neena to talk on the complicated cataract, challenging cataract cases, pediatric cataract cases. Ma'am, a humble request to please finish if possible, less than the time.
Yeah, I'm sorry I'm at this point. But anyway, thank you for this opportunity. I'll try to make it as fast as possible. Is my screen visible? So we know the challenges in pediatric cataract surgery are keeping the visual axis clear and capsular management. So I would just share a few cases which I had with me of posterior capsular challenges. So the screen is not moving. I'm sorry. Yeah, so this was a 2-year-old male child who came to us with intermittent inward squinting. And what we found that he was not cooperative with slit lamp examination. And this was his anterior segment picture on torchlight examination. You can see a central globular reflex resembling an oil droplet. So we were thinking probably it's a subluxated lens. And retinoscopy also showed an irregular reflex with a central opacity in the right eye. So we did a B scan. An ultrasound B scan showed a conical protrusion of the posterior lens capsule. So that was suggestive of something, and the rest of the pediatric and systemic examination were within normal limits. So we decided to take him up for an examination under anesthesia with a cataract surgery and IOL implantation if there is a need for that. So I'll just quickly run the video. So we can see that on the table, there was an oil droplet appearance, but as we were going, we realized actually it was a case of posterior lenticonus. And once the rhexis was done and the posterior capsule was visualized, what we could see was that there was an area of actually absent posterior capsule. Actually, that entire posterior capsule was just absent in that area, and it was filled with a bridging tissue. So you can see here, I'm actually trying to do a posterior capsular rhexis, and I'm not able to hold anything. It's just a central area of epithelial cells covering the defect. So this was actually posterior lenticonus with, just epithelial cells filling the gap. So I decided to switch on to cutter mode and remove the whole thing because I couldn't do any posterior capsular rhexis. It was already absent. and we completed it with the Rexus. And finally, 3-piece IOL was implanted with optic capture. So since we anticipated the whole thing, we used reduced parameters of irrigation aspiration. I deferred hydrodissection. The entire thing was done with bimanual IA, and care was taken to avoid AC shallowing, because here hardly there is not much cataract, but if it's a larger or a total cataract, you can expect some lens matter falling into the vitreous cavity if you do a vigorous hydrodissection. So for lack of time, I would just skip the video details. So this is with the optic capture. Finally, at the end of the surgery, we got a good outcome. So just for people to update you, posterior lenticonus is a bowing of the posterior lens capsule with progressive degeneration of the lens fibers, often associated with posterior capsular defect and cataract. Because of the intralentricular pressure and zonal attraction, there is often cataract progression. And some people even think it's due to, it's related to a persistent hyaloid artery. Mostly it's unilateral, sporadic, and isolated, but bilateral cases think about systemic conditions. It's like, Lowy syndrome. So sometimes these are, some other rare signs you get, like this fishtail sign. Can you see the movement of the cortex? So there is a posterior capsular defect through which the lens matter has actually herniated into the vitreous cavity. And when you're moving the eye, you can actually see the cortex in the anterior vitreous cavity. So you have to be very careful, avoid hydrodissection in these cases. And, you have to manage without shallowing of the anterior chamber at all points. So there are a lot of other signs. You can look up the literature. So we move on to the second case. This was a 1-year-old male child with intermittent exotropia who came to us. Again, there was a central opacity on the retinoscopy. We found a near total cataract on torchlight examination. He was uncooperative for slit lamp examination.
Can you please conclude, because we've had the talk and they are pressing us to play the session.
Yeah. Okay. So I'll just summarize. So we had this egg in the eye appearance. So this was a clue. So the egg in the appearance shows the fibrosed posterior lens capsular edges. So this is actually a case of congenital posterior capsular defect, which has progressed to a near total cataract. And you can actually, if you look carefully on the table, you can see this defect. And if you do a B scan pre-op, you can actually see this, curvature of the posterior lens capture with lens matter actually, herniating into the vitreous cavity. So I'll skip the surgical parts because we saw the posterior capsular defect on the table, and like the previous case, we managed without shallowing of the anterior chamber. We put in an IOL, we avoided hydrodissection. So again, this is a large posterior capsular defect here. You can pick it up on B scan. Child did very well. So the case 3 was again a girl who came to us with intermittent exotropia. She had a central cataract, but I could see the fundus on dilatation. And what I found that there was a stalk. I thought there was a stalk running from the disc to the lens. But when I did a B scan, I didn't find anything. So this was her appearance, a small central cataract, but the axial length was okay, comparable with both the eyes. So was it PHPV? I was doubtful. But on table, I would just quickly run this video because it is interesting. After doing the capsulorhexis and the posterior capsule, I'll actually show you the steps. So we found that there was actually a stalk here. Can you see that? Can you see the stalk there? So this was a stalk. So we actually cauterized the stalk. And because we anticipated it, we were able to get an endocautery and cauterize it and put a 3-piece IOL with optic capture because, otherwise it would have bled tremendously and, created problems for you. So this was a case of mild posterior PHPV, which presented to us in this fashion. So what I would like to say is that pediatric cataract lens aspiration is extremely easy, but because the children are not cooperative for slit lamp examination, look at the morphology properly, do B scan properly, and anticipate problems like this. If you plan well, you can get a good results. Thank you.
Thank you, Dr.
I'm sorry for
excellent talk. And our last talk is by Dr. Anupam.
There is
She'll be
one
talking on
important
aberrant
thing I would like
innovation
to
in
tell
third
you.
palsy and management.
That in any case
Dr.
of
Anupam is
cataract,
working as
if you find some white spots
additional
over the
professor at
anterior
Rishikesh
capsule,
AIMS.
calcified
And
spots,
she has been
these
doing a
are
lot of
known
good
as
work in
BA
strabismus
spots,
and
that
pediatric
is
ophthalmology.
spots.
Thank you
In
very much,
those
sir.
cases, you will see that the posterior capsule is absorbed.
I will be talking
Dr.
about
Anupam,
the
please.
management of thorn palsy with aberrant regeneration. Slides are not moving. Yes, ma'am.
please.
Aberrant denervation of third nerve is otherwise known as oculomotor synkinesis. It is an uncommon but well-described phenomenon. It can occur in both congenital and acquired cases. It can occur primarily as well without any preceding nerve palsy. And most common etiology is trauma, tumor, aneurysm, hemorrhage, or congenital or other disorders. Pathophysiology, most of us know that aberrant denervation phenomenon throughout is the peripheral misdirection of the regenerating axons. It can result from persistent partial oculomotor recovery, and the nerve fibers grow to supply muscles other than their original terminal muscles, leading to co-contraction of these muscles. There could be two forms: primary oculomotor synkinesis, typically secondary to slow-growing intracavernous lesions and without any preceding signs of third nerve palsy, and secondary mostly because of trauma, tumor, or surgery. So, clinical phenomenon of aberrant denervation can be manifest in the lid gaze or pupil gaze synkinesis. Eyelid retracts, as we here it is shown in the figure, that eyelid retracts when patient adducts his or her eyes. This is known as inverse Duane sign, or eyelid retracts when patient looks down, that is pseudo von Graefe sign. Pupil gaze synkinesis, there is a video, pupil constricts on adduction or on down gaze or on convergence. So classical treatment of third nerve palsy is ipsilateral recession resect of horizontal muscles followed by vertical transposition muscle, or PADEN if required, followed by ptosis surgery. But in 1980, O'Donnell and associates suggested a new approach by using contralateral resect procedure of horizontal muscle if there is synkinesis on adduction. So the aberrant denervation regeneration can be we can take privilege of aberrant regeneration to manage ptosis and horizontal strabismus simultaneously in these kind of patients. And the rationale is by making the fixing eye isotropic in primary position post-operatively, the innervation of lateral rectus muscle increases, and so the contralateral MR gets more supply, and so is the LPS, which is has co-contraction with the MR. Advantages are simultaneous correction of both strabismus and ptosis in single sitting, and reduces patient discomfort, and complication of ptosis surgery can be avoided. But disadvantages are performing on the sound eye surgery, which may not be feasible and very difficult to convince some patients, and eyelid retraction and adduction may become more cosmetically displeasing post-operatively. This is a case of partially recovered right third nerve palsy having video I have shown is of this patient only, having pupil gaze synkinesis, near vision was N36 preoperatively. We did horizontal muscle surgery on the other eye, and near vision improved, and the patient has some residual exo and planned for a second setting surgery. This is a case of post-traumatic left-sided partially recovered third nerve palsy having inverse Duane sign. In this case, we operated bilateral LR recession and contralateral MR resection, and we can see that ptosis is taken care of. So take-home message is contralateral surgery can be done in third nerve palsy with aberrant denervation. This allows simultaneous correction of both primary position, horizontal lesion, and ptosis in one step, and it can also improve near vision in cases of pupil gaze synkinesis. It avoids complication of ptosis surgeries. Thank you.
Thank you so much, Dr. Manpam. It was wonderful presentation. With this, we conclude, and once again, I request all to, we are looking forward to welcome you to
We can have a photograph.
Aurangabad for the midterm SPOCICon.
Yeah. Come to Aurangabad for our midterm SPOCI, that is on 24th and 25th June next month. Sir, you want to say?
Yes, I am thankful to all our speakers, then our panelists, and all audience also. And one more thing, that I am very much thankful to the entire people for encouraging our this myopia guidelines project. Thank you very much.